day will be enjoying and learning from the launch of Moving the Margins, improving adult pneumococcal vaccination uptake in marginalized groups, a study that I know you've received and prepared by ILC UK with generous support of Pfizer, who provided a charitable contribution to support this project. My name is Ruth Finkelstein, American, as you can hear from those big flat vowels. I'm the director of the Brookdale Center for Healthy Aging, Hunter College, University of New York, and also a professor of public health. So this kind of work is straight up my street, and I'm always honored to partner with ILC UK on a variety of projects. For those of you joining for the first time, ILC UK is a charity, an independent think tank on specifically focusing on the impact of longevity on society. They help to understand and plan for the future in light of demographic change. It's early here. So you all are aware, and the whole world is very aware at this moment, that vaccination remains the primary, most effective preventive strategy for prevention of many infectious diseases, and in this case, particularly older people against pneumococcal disease. We know that uptake is low across the entire adult population, but even more concerning is the fact that people from marginalized and underserved populations are the least likely to be vaccinated. And you'll see that that's true across countries, though the specific populations so affected are slightly different in different countries, depending on what the access barriers are. This publication looks at research from 8 countries to fill a gap in our understanding about inequities in adult pneumococcal vaccine uptake. We hope today that you'll be able to join a conversation after Arun gives a brief presentation to share your thoughts on the publication, examples of good practice in your country, and what you think the most important solutions would be for us to take forward nationally and to our international bodies. The housekeeping rules that should be familiar to us all by now. Once we get to the discussion, use your hands function and we'll call on you. You may want to mute when you're not speaking. There's a chat at the bottom if you want to communicate or get our attention. Please post comments on Twitter, hashtag delivering prevention, and at ILC UK. We're recording the webinar, which you recall means that your comments in the chat are noted in the recording, and presentation slides will be published tomorrow, as will the webinar right here on your YouTube channel. So I'd like to now introduce Arun Himawan. Sorry, we didn't go over best pronunciation, my bad. Who's the Senior Health Research Lead at ILC UK and the accomplished author of this report. Take it away.
Thank you so much, Ruth. I'm just trying to change the slides here. having a little bit of issue before, but we've already had a welcome, so thanks for that. Really grateful to have everyone join today. Before I get into sort of the research, the findings of the research, I thought I'd just give a very quick recap to those of you who are joining us for the first time who the ILC is. So Ruth already mentioned that we're the UK specialist think tank on the impact of longevity on society. But one of the things you may not know is we're also one of the founding members of the ILC Global Alliance, which is an international network on longevity with members across 16 countries. And actually, they were particularly helpful in helping me identify people within the various countries that I was doing my research. So I just want to say, quick, huge thank you to them. This research wouldn't have been possible without their support. So a little bit of background about why, about the research itself. So we conducted 34 stakeholder interviews with experts from 8 different countries. So lots of different views here. And we actually have a great mix of stakeholders, from immunization experts to public health experts to doctors, pharmacists. And we also spoke to charities and organizations that work directly with marginalized and underserved populations. So lots of different perspectives here that really helped to bring the findings of this report to life. And so one of the reasons that we wanted to do this research was we identified there was a gap in the existing literature. There's very little on adult pneumococcal vaccine uptake generally, but there's even less data and literature on inequalities and uptake. So we really saw this as an opportunity to fill that research gap. And we wanted to ultimately really understand the inequalities that exist in the adult pneumococcal vaccination uptake. We wanted to understand the barriers facing marginalized and underserved populations. And we also wanted to identify the solutions to tackle these barriers and reduce inequalities in uptake. So why does this research matter? Well, I obviously already mentioned that there was a gap in the research, but there's a few other things to take into account. So first of all, we know that vaccines are one of the most important and effective forms of primary prevention in an aging world, and it can significantly improve health outcomes. But what we also know is, at least across OECD countries, they spend less than 3% of their total health budgets on preventative healthcare. And of that preventative healthcare budget, there's less than 10% that's directed towards immunization programs. So there's very little support going towards adult immunization, especially within considering that the majority of immunization programs, the focus is on childhood immunization. But we also know at the same time that there is a meaningful push to safeguard population health at both the global and regional level, in light of the significant toll that the COVID pandemic has had on societies and the rise in inequalities. So the EU's revised global health strategy and the World Health Organization's immunization agenda, which prioritizes life course immunization and vaccination equity, are key opportunities for us to influence and have a say on what we can do to address inequalities in uptake. So a little bit of a background about pneumococcal disease. So pneumococcal disease causes 1.6 million deaths every year across the world. And older people are at increased risk of pneumococcal infections regardless of their health. And this is because their immune system naturally weakens with age. Approximately 3 million cases of community-acquired pneumonia are expected every year across Europe. And of these cases, a third, or 1 million people, are hospitalized. Pneumococcal pneumonia is the most common type of bacterial pneumonia. Patients with this type are 3 times more likely to die than patients with pneumonia of other causes. And it's particularly dangerous for older adults. US research, for instance, identifies that people over the age of 65 over 10 times more likely to be hospitalized with pneumococcal pneumonia than those aged between 18 to 49. So what we know is often when it comes to health, those who are marginalized, come from marginalized and underserved groups are historically least likely to have access to healthcare. And for vaccination, there's no exception as well. So taking one example from the US, and actually most of the data that we have on inequalities and uptake for the pneumococcal vaccine comes from the US. But taking them as an example, one study found that there was a 23.5% gap in vaccination rates between the lowest and highest income deciles for pneumococcal vaccine uptake. So when we're talking about inequalities, we're not talking about small differences in uptake. We're actually talking about huge differences and inequalities. And this is something that absolutely needs to be tackled. So what does it look like across our countries? What's going on in terms of the pneumococcal vaccination uptake? So taking a look at the table first, as you can see, all the countries that we research offer the pneumococcal vaccine or recommend the pneumococcal vaccine to older adults. Of course, the age at which they recommend does vary, and which vaccine they recommend also varies. And you can also see that for most of the countries, it is free. However, for places like the US and Japan, it's not. Taking a look at figure 1, you can also see that there are significant inequalities in uptake across these countries, with the Netherlands leading and Japan trailing, although it is sometimes difficult to make direct comparisons, mostly because of the nature of the data, and we don't have it for the same years. And we also don't have it for all the entire population within each country. That just goes to show that data is continuously is lacking on this topic. So that's something that needs to be addressed, and that's something that came through our when speaking to our participants. Okay, so what we know is that there are significant uptake inequalities by demographic groups. These do exist. And so a lot of stakeholders mentioned various different groups, but I think these are sort of the key groups that they identified as being at risk of poor uptake. And so a lot of these are probably unlikely to raise any red flags. We probably already know this as a result of just generally our knowledge on vaccination uptake, but just to give you a sense of what people were saying, and there were, of course, some country differences here. So people from ethnic minorities, of course, this was a huge group that many countries, participants from many countries identified. Specifically, there was a focus on migrant population. So in this research, we sort of identified or realized that a lot of stakeholders were talking about people who had recently moved to their country of residence or had been born outside of their country of residence. So the biggest issues here, or the biggest barriers for them, was cultural differences and language barriers. So these two being sort of the biggest things preventing them from getting vaccinated. Just to give one example, we had one stakeholder talk about how first-generation Turkish women who immigrated to Germany in the 60s were more likely to live alone, not speak German, and were more likely to be unvaccinated. Indigenous populations was also a group that was identified, especially by people from Canada and Australia. Interesting with Australia is that they actually offer the vaccine to their Indigenous populations at age 50 or over, and also offer additional booster vaccinations for this population because they have specifically identified them as being at much greater risk than the rest of the population. People from low incomes, as you probably are unsurprised by, were mostly identified by stakeholders from Japan and the US. So again, here, interestingly, in Japan, the implementation of the pneumococcal immunization program is under municipal control rather than under the jurisdiction of national government. So under the system, only some municipalities are eligible for a national subsidy. And so with that, they may also elect to further subsidize the cost of vaccination, while ineligible municipalities may only subsidize a portion of the cost for patients. So patients will have to pay for the vaccine. Undocumented and homeless people, again, US and Japan, there was a bit more people talking about undocumented and homeless people. In the US, especially those coming from Central and South America. And then we also had those with conservative political attitudes. Again, here, this was sort of identified by a few participants from different countries from the US and Germany. And finally, those living in areas with poor healthcare infrastructure. Of course, a lot of the time when we talk about this in places like Canada, Australia, the US, we talk about people living in rural areas. However, that's not necessarily always the case. And in fact, some of our participants from Europe had raised the point that actually some rural communities might be better placed to deliver healthcare because everything is in one place and people can easily access it. Now, Obviously, that's not going to be the case everywhere, but it's interesting to highlight nonetheless. So what we can see is there are several barriers contributing to inequity in uptake. And the first one is lack of data. So what we found was there's generally lack of data across the whole adult population at a national or regional level. And it was very clear from our stakeholders that we need to have good data, and we need this alongside rates of infection so we can closely monitor what's going on. When it comes to marginalized and underserved populations, data was virtually non-existent. So this is clearly something that needs to be tackled, and we need to start monitoring that more. So it was very clear from our stakeholders that it's unlikely that governments will prioritize vaccination without good data to prove why it's really worthwhile. The other issue with lack of data revolves around electronic health record systems. So for some participants from Canada and the US, they mentioned that a lot of the onus is on individuals to remember if they're vaccinated. So those in precarious situations, such as migrant workers or homeless people, are unlikely to know whether they've had the vaccine and therefore unlikely to ask for it. Lack of targeted messaging was also a barrier. And so this is particularly for those from ethnic minorities or migrant groups. And this could essentially lead to vaccine hesitancy. So some of our participants were talking about how messaging absolutely needs to be co-designed. And there's one example that you can see from the quotes from Anna from Germany, who talks about how during the COVID pandemic, the government in Germany was trying to reach various different migrant groups, but because they didn't get the communication quite right, there was cultural differences in the communication. Actually, they didn't see improvements in uptake of the COVID vaccination. So it just drives home the importance of really understanding the communities in which you're targeting messaging for, and working with community organizations to really ensure that you're getting that messaging right. Interestingly, but not oftenly commented on, was the oldest old not being being a marginalizer, being from a marginalized top group. And so we had one participant talk about this from Spain. It was something that was really worrying her because they felt that they were just not being reached through the sort of common modes of communication. So a lot of communication is through social media, and a lot of these people living in rural areas don't have access to social media, don't have access to Wi-Fi. So really making sure that there's a diversity in the way in which we're trying to reach, in the way that we're trying to reach people. So access barriers, again, a huge barrier for many marginalized groups. Again, particularly those from resource poor settings and those on low incomes, those also receiving care. So for instance, some people talked about how, because older adults will be reliant on their caregivers to take them to see a GP, that could potentially be a barrier. And then of course, those living with disabilities might also be affected. Access barriers in terms of cost, again, US and Japan, lots of participants talked about that. But what was quite interesting about this was that even those, so taking the US as an example, even those who are covered by their health insurance, cost could still be a barrier. You can see the quote from Stephanie below, just talking about why this can still be a barrier, because the health insurance system reimburses you after you pay for the vaccine, often when someone has to decide between buying groceries or buying the vaccine. Even with the reimbursement, the groceries are always going to win. So still some barriers to cost there. And of course, there's also barriers in terms of lack of trust in governments and health systems. And many groups can be affected. Again, here, ethnic minority, indigenous groups. We also had some people talking about the LGBT community. But there's likely to be lots of other groups that are affected by lack of trust. And obviously there's going to be country differences, regional differences as well that you need to really identify and understand. So the example or the quote from Laura on this slide is quite telling, because it really identifies and shows how, again, even taking population health management approaches, which can be quite effective in reaching those at risk of poor uptake, can still backfire, can still have the opposite effect of which we intended. And so that's something, again, that really was identified through our conversations, was working alongside community groups, really understanding what's going on and really sort of coupling population health management, which is a really important approach, with working with community groups and really identifying what are the reasons for why they're lacking trust in various institutions, and really uncovering that. So working with trusted leaders within the community can be a good way to overcome this, but not necessarily the only way to do it. But really really identifying what those barriers are is going to be really important if you want to be successful in reaching marginalized groups. So alongside this, it's quite hard to avoid the fact that there are a number of structural barriers that contribute to suboptimal uptake. When I talk about structural barriers, what I really mean here is barriers that affect the entire adult population. Now, this is obviously going to affect marginalized and underserved populations as well. So it's really important that we identify these also and understand what's going on here. So the first one is around lack of effort to educate the public and improve uptake. So the first point here is the fact that there's generally no call or recall invitations to letting people know that they're eligible for the vaccine. And there's alongside that very few public health campaigns to educate people on pneumococcal disease and on the vaccination. So essentially people are unaware of the risks of being unvaccinated, or even if they're eligible. And we already know from some studies, including a Europe-wide study, that awareness is very low, with only 29% being aware that it's even possible to be vaccinated against pneumonia. Interestingly, Netherlands and Japan have both implemented national pneumococcal vaccination programs. And so in the case of Japan, it actually has seen some improvements. Coverage rates have doubled since they've implemented the 5-year program. But even with this, stakeholders had mentioned, both from the Netherlands and Japan, that a lack of communication is still preventing further gains. If you take, again, Japan as an example, individuals receive one letter. So if that's getting lost, if people don't read it, they're not going to get that vaccine. So it's really important to constantly remind people that they are eligible and that they can be vaccinated. There's also a lack of awareness among healthcare professionals. So healthcare professionals were often cited as the single most important campaigner. So if they're not reminding patients, if doctors aren't reminding patients, or anyone who can administer the vaccine aren't recommending it to patients, they're unlikely to take it. So it really has to start from sort of even the individual level, as well as wider policy changes also. There were also some concerns around unclear and changing recommendations, and this was by participants from Australia, the US, and the UK. So in the case of the US, there was a little bit of concern as to the fact that 2 different vaccines are offered. Obviously, the CDC can't favor one manufacturer over the other, but without giving additional information, there was a worry that about benefits and drawbacks of the vaccine. There was a worry that, again, individuals may feel as though they have to make a decision on which vaccine would be better for them, when actually it's really just an illusion of choice, because they will, in reality, will receive whichever is available to them when they go and get vaccinated. However, this can still make a vaccination less convenient and contribute to vaccine hesitancy, because individuals may just feel, well, I have all these options, so I may not make the decision now and I may not go and get vaccinated. In the UK, the Joint Committee on Vaccination and Immunization had stopped offering the pneumococcal vaccination for a brief period in 2013. And there was a worry that this has contributed, or has had a long-term effect on healthcare professionals lacking confidence in the vaccine, and so not necessarily recommending it all the time. And in Australia, there have been recent changes to the eligibility and which vaccine is recommended. And this happened during COVID. And because COVID disrupted routine immunization, there was also concern as to whether healthcare professionals were actually aware of these changes and if they were actively recommending it to the right populations. And then finally, one of the other barriers is that the system isn't set up to to improve uptake in adults. So this has to do with things like national immunization technical advisory groups aren't always diverse. So there was definitely sort of a consensus around needing representatives for older adults, experts in adult immunization, along with experts in in the needs of key marginalized groups. There was also concern around the fact that few can offer the vaccine. Obviously, again, there are differences across countries, but there was a lot of people did talk about how we do need specialists who see, patients clinically at risk, being at the very least able to advise patients that they're eligible for the vaccine and ideally be able to administer it as well. Alongside this was also the point around widening who can deliver the vaccine. So nurses, pharmacists can significantly improve uptake across the board. And we've seen lots of examples during COVID of how involving various healthcare professionals can actually make a big difference in reaching those groups that tend to not access healthcare as frequently as others. So in terms of our solutions, I think one of the things with a global piece of work is trying to get an understanding of what are the key things that that we can do to improve tackle inequalities and uptake. So sort of starting at the WHO level, we asked that the WHO call on all developed EU member states to implement a coverage target of 75% for all adult pneumococcal vaccination. So that's similar to the existing target for flu. We also have several recommendations for national governments. So this includes implementing a national 10-year strategy to reduce health inequalities with clear targets and close monitoring. This should be in line with the WHO's immunization agenda with targets to improve inequalities in immunization across the life course. We should also ensure mandatory reporting of adult pneumococcal vaccination in National Immunization Register. This will, of course, help with achieving national immunization targets. And we should also make it standard practice for health systems to collect routine vaccination uptake data for patients from different demographic groups. So the UK and the US currently capture data about uptake inequalities for flu vaccination across different demographics. So this really should be scaled up across all the countries of focus in this report. And ensure that it can be used to implement targeted health management approaches. We should also implement a call and recall system for adult pneumococcal vaccination. So each vaccination invitation should be accompanied by educational information on pneumococcal disease and on the benefits of vaccination and on the risks of not being vaccinated. We should also ensure that those who may be at greatest risk of low uptake don't bear the cost of paying for vaccination. So obviously for the countries that's relevant for, this is going to be really important. So offering incentives such as vouchers to marginalized and underserved groups could be one way to tackle this. And we also need to invest in electronic health record systems for vaccination. We should not forget the role that technology can play, whilst at the same time not ensuring that everyone is able to access these programs and interventions as well. So, giving individuals access to their own data to allow them to take control of their health is really important so that they know what they've been vaccinated against. Electronic health records should be supported by additional health information on routine adult immunization, and it should again be tailored to different demographic groups and making sure that it's culturally appropriate so that we're addressing some of the top level barriers that I've identified in this research. Public health bodies in partnership with third sector and community organizations that represent marginalized groups also have a role to play here. And so for them, we really see looking at considering a system of accreditation for healthcare providers to indicate those with inclusive and diverse spaces. This may help marginalized groups to feel safe accessing services. Countries should consider adopting the pride and practice in the NHS Rainbow Badge program currently used in the UK. And also look at investing in targeted public awareness campaigns. And they should also fund programs that specifically tackle vaccine hesitancy. So campaigns should really be targeted to different groups by highlighting key concerns for each one. Consider including information on the pneumococcal vaccination alongside other vaccine preventable diseases like flu. Campaigns should be run regularly to ensure that the message really reaches those groups. Healthcare systems should also look at implementing a role of immunization lead in each primary care practice. So this is something that's currently done in the UK. It could be a nurse, it could be a doctor with the requisite knowledge and expertise on immunization, and who's responsible for ensuring targets are met and that patients eligible for vaccination are invited, and that the practices healthcare professionals understand the importance of immunization. And we should also ensure that NITAGs prioritize adult vaccination by involving stakeholders who are experts on adult immunization, like I mentioned before, ensuring that we're really talking to the right people that can really help to improve uptake for these various different groups. And we also need to involve healthcare professionals who aren't doctors or nurses in the administration of vaccination. So anyone who works with people who are from clinical at-risk groups should be able to educate patients, ideally administer the vaccine. And like I said, really, this will really help to widen access. And then finally, we should also allow individuals to receive multiple vaccinations during one clinic visit, so that it's not an extra burden for people to come every time for a different vaccine. This can make it much easier, can make delivery of vaccination much more efficient for healthcare providers themselves, but then for individuals also. So thank you all so much for listening, and I look forward to the discussion that we'll have now. Oh, Ruth, I think you're on mute.
It's not a meeting if I don't try to speak while I'm on mute, you know. So that was a very informative conversation with some New York style fast talking by the end, but I think the slides help people too. I am hoping that we don't have to prime the pump of discussion too much, because there's rich considerations, but maybe we could start out by just getting people to share from your experience in your country, in your setting, in your practice, which of the recommendations seem to you like they would yield the most, or on the other hand, not reach your group at all. Could we start by thinking in terms of kind of the applicability of those recommendations to your different settings and experiences? If you want to participate, you need to put your cameras on so we can see you. B, unmute yourself, and C, use that little wave hand function down at the bottom, which is in the participants button. But there are few enough of us, we're in the range of 20 people, that I'll see you waving your hand around. That is, if you put your camera on. If, however, you leave your camera off, I will not see you waving your hand around in the miracle that is Zoom. So does anybody have a reflection on those recommendations to get us started? Well, I can broaden from the US case a little bit. So while it is the case that there's a charge for vaccines, my colleague at Yale works more with epidemiologic data than health policy data. And we do have prevention guidelines in the US, and the pneumococcal vaccine are covered in the prevention guidelines, which means Medicare covers pneumococcal vaccine without charge. So the people who have to pay up front or aren't covered at all are undocumented people when you're looking at the 65 and over group, just to sort of complicate that story. What is absolutely the case is that nobody knows that. So the system is so complicated. So I have a note in the chat that says, I have two people with hands up, but here's what's true. I have nobody with camera. I have one person with their camera on, and I can't see your hands. So if there's somebody who can see people's hands, please call on them because I can't.
So Ruth, I think Julia had her hand raised or would like to say something.
Wonderful.
I don't see her hand raised right now, but Julia, would you like to come in and say a couple words?
Yes, could you hear me now?
Perfectly.
Yes. Well, I think for all the people like me, it's sometimes difficult to believe in so many vaccinations here and there and everywhere. Yeah. Because we were born in the time where there was no such a big amount of vaccination. When I was only 7 years old, I got pneumonia. It was hard. They treat me with an injection of, what was it? I don't know, some injections. And I survived. And I have considered myself immune to pneumonia again, which is hearing you now. I realize that I'm not at all. So it's sometimes it's difficult. That's what I want to represent for all the people, for us to believe in vaccination. I don't know how you can convince us. It's very difficult to convince us because we tend to think that when we have too many of these vaccinations, it's going to be bad for our body.
Right. Thank you so much, Julia. I really appreciate your bringing your direct lived perspective. And I want you to know that I too am in the vaccinate them all the time age group. And I too am like, oh my goodness, shingles again, pneumonia again. It's really overwhelming to me, and I'm in the field, so I very much feel you. But I do think that if we had broader and more consistent messaging, so that we sort of saw it on the, I don't know, where do you live? Can you?
Well, in this moment, I live in England.
Okay.
But in those days when I got the pneumonia, I was in Chile.
Okay.
And for instance, now for the COVID vaccination, it has been difficult for me to get all the jabs. I have only 3. I haven't gone to number 4.
Okay.
And I went traveling and I got COVID very hard. Yeah. So maybe I will have number 4 now.
Okay, well, consider us your support group for number 4. Please, after your immunity time is over, go get it. Yes, Patrick.
Yeah. Yes. So now that I have had the COVID, I am immune or not?
You're immune. Your immunity is higher for 2 to 3 months. When did you test negative the last time?
And for pneumonia, I'm not at all after having it when I was 7 years old.
You need your pneumococcal vaccine unequivocally, and you need your 4th COVID jab unequivocally, okay?
Okay, thank you very much for your advice.
You're welcome. Patrick.
Yeah, I'd second that. I'd say, yeah, it's pneumococcal vaccination in the UK, though. I think one of the challenges is obviously because it's every 5 years after you turn 65, it's at different intervals. So I think that's one of the challenges, is trying to relay to people that it's really important to continuously get your vaccinations. But there is this idea that we have vaccine fatigue at the moment because there is so much going on in the news about COVID-19 vaccination. You hear it each year with seasonal flu vaccination, but I'd highly recommend it to anyone. Obviously, it's our best form of prevention. I just wanted to say, Aaron, I thought it was a really good presentation. I really liked the ideas that we've kind of presented at ILC. I think we've been saying a lot of those kind of things for a while as well, especially around data. I'm currently trying to produce a pneumococcal atlas looking at vaccination, pneumococcal vaccination across 42 European countries. And the one thing when I look at vaccination, particularly in clinical risk groups and older adults, so the more vulnerable populations, is that there is no data. And then it drives me up the wall because I'm like, where is it? Where can I find it? And I think it's because of this mindset that we have it in our heads that vaccination is very much something for children and it's not taken as a life course approach. That's what makes it very difficult. And it's not enough political will or not enough decision-making power being made by governments, healthcare providers to record data in different population groups that we struggle to find that data. So I think, you know, I can easily go on the WHO website and find PCV3 vaccination in children under the age of 2. I can easily find that actually, yeah, it's pretty good. It's around 90+% for like most European countries. But when it comes to older adults and clinical risk groups, there's no data. So yeah, if I had one magic wand and I could wave it, it would be make sure that countries report on data for sure. The one thing I would say, and I think the challenge that we would find with some of these recommendations is actually trying to, you know, make some kind of consistent one-size-fits-all policy recommendation. Recommendations obviously vary by age group when you get to the older adults. So across Europe, for example, Poland and Slovakia, they might recommend vaccination for people aged 50 and over. Germany recommends it from people aged 60 plus, but then when you get to somewhere like the Netherlands, it's age 75 plus at different intervals, I believe. But my point being is there's loads of different recommendations and there's not a lot of consistency, whereas flu is predominantly 65 plus. I think it really does vary with pneumococcal vaccination. So my one thing I would be saying as well is ensuring that we are very consistent with our recommendations, ensuring that there's a more kind of cohesive recommendations being given, especially across Europe. I think it would help increase people's awareness. If people got to a certain age and recognize that they are recommended a certain vaccination, they would be more likely to get it. But that's just my opinion. And I think it does make it harder to record data when there are different recommendations floating around. So that's the one challenge I think we have. But certainly, yes, Aaron, I agree. More data, certainly more tailored communication as well. It's vital that we kind of communicate to the right people through the right channels about the need to get vaccinated. But yes, give me more data. Let me crunch those numbers. That's what I would say.
All right. The creed accord, give me more data. Jenny.
Hi, thanks everyone. It's been a really interesting session. I think really I just want to echo what you said earlier, Ruth, and Julia, you gave a perfect example that you've learned something from this webinar, and I think that consistent and clear information would be my biggest thing. Sorry, I realised I didn't introduce myself. I work at Age UK, charity that represent older people in England. And yeah, I think for me it's the consistent and clear communication. Julia was a perfect example. She wasn't aware that you needed another top up of your pneumococcal vaccine, and I think making sure that there is clear and consistent communication across kind of all the different variety of vaccines, because I think, you know, we're better at some than others. Pneumococcal is particularly one in this country where actually awareness is quite low around the vaccination. Flu and COVID is a bit better at the moment, but certainly not perfect. So I think for me, the clear and consistent communication, and yes, targeted. I think Aaron, when I spoke to you when you were kind of writing up this report, we talked about I think one of the biggest successes of the COVID vaccination program in this in the last couple of years was there was a real concerted effort financially and all the other things that meant that, you know, communication was mostly clear. It was kind of put out through multiple channels and it was targeted where it needed to be, and that's, you know, part of the reason of the great success of it, I think. So yeah, that would be my I mean, all of them would be great, but that would be my main one, I think.
Great, thank you. I will also add we did a lot of research with older adults, Ray, COVID uptake and COVID vaccine uptake. And one of the things that we learned won't surprise anyone on the call, but I'll state the obvious anyway, was that the more messages change and the more variable they are, the more confused people get. And the result is that they lose confidence in the messenger. So it's not just that, oh, do I do A or do I do B? They say, forget it, I'm doing neither A nor B because they can't make their minds up about it. So sometimes in the face of different age recommendations, and the truth is the age is not cut and dry. If you have a compromised immune system, you want those adult vaccinations earlier, and guidelines suggest you get it. So that's why sometimes campaigns are ask your doctor about the pneumococcal vaccine. Ask your doctor if you need the pneumococcal vaccine. And then our job is to be sure that any healthcare provider, or ask your pharmacist, or ask your nurse. And then we have the somewhat more efficient, potentially, job of being sure that all those healthcare providers are well educated about, yes, you do, and here's how to get it, if you can't just give the jab right then and there when someone reaches it. Okay. So do we have other input on that question about recommendations? Because we can move on to think about this in an additional way or two. Or do we have other people who would like to share success experiences in their settings? Has anybody run successful adult immunization programs of any kind that they wanted to tell us about? No, not that crowd. Okay. So
I've heard from everybody. Hello.
Hi.
Hi. Yeah, I was just saying that I'm happy to come in just to respond to some of what people have said, if that's okay, and just to flag a few things, just that sort of popped into my head as I was listening to everyone speak. And I think so I think what's really interesting is just that key point around messaging. When I was speaking to people, I think with the inequalities issue, because there's a lack of data, we also don't know necessarily what's going on in various different countries. You know, are the inequalities as bad as we think they are? Are they not? So often people were talking about COVID, they were talking about flu, because that's what we have information about. But there was this general sense that there's likely to be the same inequalities for pneumococcal, and they're likely to be worse because of the lack of infrastructure. And so I think for a lot of people, we hadn't really got to, and I think how it normally works with public health is you have a health, there's a health issue at stake. The first thing is to ensure that everybody across the population can get access to healthcare and can get, either preventative treatment or treated. And then the second step is to identify those who are potentially left behind. So I think the conversation from what I gathered was generally a sense that we haven't really got to that point around inequalities in pneumococcal vaccine uptakes yet, because there are so many countries struggling with just improving the coverage rates across the adult population. So that's why part of this project and part of the findings focus on sort of these structural things that need to change. That's certainly going to help the entire adult population. It's going to help improve coverage rates generally across the board, but then addressing these inequalities will help to sort of reduce the inequalities between the rest of the population and these various marginalized groups. When you look at Australia, for instance, and they have, that specific recommendation for their Aboriginal and Torres Strait Islanders, actually, since it's been implemented, there's data to suggest that uptake's gone down. So it's interesting because obviously having that and allowing them to be eligible at a younger age is certainly part of the issue, but clearly it's not addressing everything to do with a low uptake, because there's likely to be other issues around lack of trust, poor messaging, those sorts of things that I've raised around specific to inequality. So there's just a few things that I think are really interesting in terms of talking about the pneumococcal vaccination. And I'm hoping, there will be more of a focus on inequalities. And I think there is, like I mentioned, there is that opportunity to engage on this topic, especially because of the inequalities that have sort of been exposed during the pandemic.
Mm-hmm. I will say that 20-point spread is very familiar. It's true. It's there in annual flu vaccine in the US. It's actually not there for COVID vaccination now. It's there in a number of countries for flu vaccine, but what you've got is a lower baseline for pneumococcal. So at its highest, it's lower than flu is. And so then when you take 20 points away, you're to really, really low. But obviously that 20-point spread is unconscionable and insupportable, but the fact that we have it over and over again suggests that there are fundamental issues that we have not yet identified. And the fact that it runs across countries with different histories of what the way their medical system has treated different groups of people across different systems of access means that it is itself an important topic of study, like what's up with those 20 points. Can we get other insight into that? Arun or others who have studied this area, like specifically toward the difference?
Yeah, I mean, I think addressing the inequalities is going to help with reducing that difference. So there's certainly things that we aren't doing, that we aren't understanding, and maybe it's a question, like Jenny had mentioned, taking the resource that we had during COVID and really seeing how that could help various different groups, and working with local communities as well could be quite important. I'm just a bit conscious of time, and I see that Jenny has her hand up again. I don't know if she wanted to come back in, but maybe she could end with a final comment before we just go to closing remarks, if that's all right with you.
Yeah, sorry if we've got time. It was Aaron, what you were saying about we know a bit more about flu and COVID just because of data, and but I think what that provides us is really an opportunity to embed addressing inequalities for other vaccinations at an earlier stage before, because if you get it right for people who are experiencing inequalities, you get it right for the majority of people. So I think you're right. But I don't think necessarily we should wait until we're at 70% coverage for pneumococcal to start kind of addressing those health inequalities, which I think is what you were saying, but just wanted to highlight that.
Really?
Yeah, I do think that that's generally the way that we approach public health. It's not the right way, because you're absolutely right. We need to be having we need to have the right structures in place, and we also need to be tackling inequalities at the same time. I also had a respondent from Canada talk about how during the COVID pandemic, they were they had all this data, and they started reaching out to various communities, and then they realized that actually they needed to use the data that they had on inequalities to actually target the work that they were doing, but they didn't realize how important it was until after they started their messaging. So there's a little bit of a back and forth, and it sounds like, and even with COVID, that the issue around inequalities is not something that is taken into account from the outset. And I think at least in the UK, and I remember seeing when inequalities were, kind of taking center stage in the media, thinking, well, we kind of knew this already about other health issues. I mean, this shouldn't be a surprise to anybody that ethnic minorities often have poorer health outcomes, face barriers, that various different communities have face these inequalities, and we should have been thinking about it from the beginning. So yes.
Wonderful. Well, thank you so much, Arun, for your incredibly erudite presentation, and to ILC UK for, as always, bringing us perspective and in-depth look at issues we need to look at. The full report is on the ILC UK website, and please follow on there, including on Facebook and Twitter at ILC UK, in order to see the latest and greatest that comes from there. And thank you again to Pfizer. Thank you again to ILC UK. Thank you again to everybody who stayed up late or got up early, whatever it was, and hope to see you at another webinar in the near future.
Thank you.